This is Dr. Michael Lee. I'm a physician in interventional radiology at San Antonio, Texas. I practice with the physicians at Central Cardiovascular Institute, and we're going to present two interesting renal stent cases. The first of which is a 78-year-old female with a history of malignant hypertension who was on 6 medications, who presented with a positive troponins and mild chest pain, which resolved. The patient also has a history of renal insufficiency with a creatinine of 1.6. You can see on the initial pigtail run from the right common femoral access, disease involving the patient's distal abdominal aorta with high-grade stenosis, estimated 60% or possibly more of the right renal artery. It was slightly higher on more select views. There's two different types of approach in terms of getting access into the renal arteries for successful stenting. The first is that of a 4 to 5 French diagnostic catheter, which is used to select the renal artery, followed by wire access. Once the wire is in position, the guiding catheter or sheath is then gently advanced over the catheter in a coaxial system. Occasionally you can remove the diagnostic catheter and have the guiding catheter or sheath advanced over top of the guide wire itself. Advantages to this 4 to 5 French technique include being low profile, as well as the potential for less embolic debris that can be created. Disadvantages include that it's an extra step, and you may lose access when advancing the guiding catheter or sheath over top. Another disadvantage includes the possibility of that the catheter may dig into the renal artery as you're removing it. This is a separate case but documents the technique, pigtail run, then selection of the catheter with a 4-5 French omniflush catheter, advancing a guide wire into the stenosis and into the renal artery, and then removing the catheter and advancing your guiding catheter or your sheath in positioning, and then proceeding with the renal stenting. Next, the alternative way is a technique we've learned from our cardiology colleagues, and that is to quite simply use a 6 or 7 French guiding catheter near the ostium of the renal artery with very minimal manipulations, crossing the lesion with a guide wire, and then performing primary stenting. Advantages for this technique include it's very efficient, taking approximately 15 minutes or so. You can use a guiding catheter as a platform to cross with different O14 guide wires if needed. Disadvantages: excess manipulation can cause embolic debris if not careful, and this is continuing on. There's a no-touch technique that was initially discussed by Doctors Feldman and all, in which they advanced a 0.35 guide wire into the aorta, followed by that of the guiding catheter, and essentially kept the guiding catheter from engaging into the ostium of the renal artery. Period. Once the guiding catheter was in close proximity to the renal artery, 0.14 guide wire was then crossed across the lesion, and the 0.35 guide wire was removed, allowing the procedure to continue. But as you can see from this case that we're performing, you can see the guiding catheter in position with the use of a 0.35 guide wire. Period. However, the guiding catheter does not engage near the renal artery and does not have the appropriate bend in order to allow the O14 to advance easily into the lesion itself. And so sometimes this no-touch technique doesn't allow you to gain safe access with the use of the guiding catheter. Occasionally, with the guide wire removed, we'll go ahead and allow the guiding catheter to get closer to that of the ostium, and again, minimizing the manipulations as much as possible. And we've called this technique the limited no-touch technique, as you can see popularized here in this beach in Cairns. Once the guiding catheter is in position and near the ostium, we'll go ahead and then cross with an O14 guide wire of choice. And again, the objectives, as you can see with the 6 French guide, with the 0.35 guide wire that's in position here, that then will be removed, allowing the O14 guide wire on this run to then cross the lesion and get in position. There's been some discussion in terms of what is your favorite O14 guide wire for renal stenting. Obviously, the SpartaCore by Guidant has been very good for us, offering a lot of support. But on this case that we're showing, it did not have the necessary torque in order to get through some of these lesions. So we're very quick to go to a conventional wire such as a BMW. Other wires such as a PT2 from Boston Scientific is good, and likewise a As mentioned, the PT2 is awfully good, and then Cordis Regatta wire is also excellent wire too. And you can see from this case that the SpartaCore had some difficulty crossing. We switched to the PT2, but be very mindful of the PT2 and the hydrophilic wires that they don't perforate as they go too distal on some of these lesions. So you have to be very mindful of where the guide wire is in position. And you can see from the run here Next, we'll go ahead and advance the stent using a primary stent technique. And a few hints that we'll look for carefully is, first of all, we try to get the best oblique view of the renal ostium, that of the aorta. We'll gently pull the guiding catheter back to expose the stent, being careful not to push forward the stent with as minimal manipulations as possible. And finally, no air, making sure we aspirate as well, that the potential emboli that might be in the guiding catheter are removed carefully. Next, we'll go ahead and then inflate the balloon, and then we'll oftentimes go to the proximal end and dilate the proximal end in order to have it flare slightly in the aorta. In these final completion runs, you can see good flow through the stent. And what we're looking at, first of all, the wire position. As you can see, it's a little too far distal, and you have to be very mindful of the wire tip in this area. We'll look for make sure there's no dissection, no filling defects inside the stent, no evidence of distal emboli. And again, no evidence of perforation. On the final angiogram, we'll pull the guide wire back or out for a final view. And you can see good flow through the stent with improvement on the patient's symptoms that subsequently came the next couple weeks afterwards. One last additional tip for renal stenting. Watch for normal respiratory motion of the kidneys, and you can see the wide swing of the renal artery with respiration, as well as for the importance of having the stent protrude into the aorta for approximately 1 to 2 millimeters to make sure that the ostium is adequately covered. And that summarizes this first case, and we'll go ahead and go on to the next.